Hi, I'm David Ridley. My guest is Professor Regina Herzlinger. She's a pioneer. She was the first woman tenured at Harvard Business School. She is the Nancy McPherson Professor of Business Administration at Harvard. She's a passionate advocate for using consumer-driven markets to solve problems in healthcare. She's the world's greatest writer of healthcare business cases. I've used her case studies on topics including high deductible health plans and specialty hospitals. She's also the author of several books, including Who Killed Healthcare? And her latest book, Innovating in Healthcare. Reggie, do you have your latest book handy?
Funny you should ask. So it's got this Keith Haring-like series. I don't know if any of you follow art, but Keith Haring is an innovative artist who uses cartoon-like figures to convey his view of the world. And my publisher kindly commissioned that kind of cover for Innovating in Healthcare. Publisher is Wiley, and I'm lucky enough to have just one of the most brilliant editors I've ever encountered in editing the book.
Let's talk about healthcare innovation. What are the keys to healthcare innovation for a company?
Well, for a company, it implies that it is an existing entity that for one reason or another needs to innovate. And the choices it has are to create new products, create new channels for distribution of those products, or go to different markets, by which I mean different countries, different segments of society. Innovation within a firm is difficult, and it's difficult because the people within the firm, consciously or not, resist innovation. For example, I was on the board of a pharmaceutical company which introduced the first interferon. To introduce that interferon, the CEO, who was a lawyer, not a scientist, created a separate office to do the R&D and the business plan that reported only to him. And his fear was that the existing R&D people who were used to dealing with non-biotechnology products would kill the new product. I have many instances in my case studies of existing firms that tried to innovate, where either the firm buys an innovative new product line and kills it. Doesn't mean to kill it, but it kills it. Or it does what this brilliant CEO of the pharma did, and that is sets up a whole new enterprise, different reporting structure, sometimes even physically different, to ensure that the baby isn't killed. Innovating without a firm, that's a different story. So what I find is there are lots of ideas. Healthcare is a very inefficient industry. The quality, we have great doctors, great hospitals, great researchers, which we certainly see with COVID, great resources, great, but it's an inefficient and ineffective industry in the sense that we really don't know how good it is. We have, other than for things that go through the FDA, we don't have metrics of quality. Don't know how good really our doctors are, or our hospitals are, or our imaging centers are. So the quality may be high, maybe not, we don't know. And although we spend so much money, and countries all over the world, certainly developed countries, spend so much money, even with universal coverage, access is very inequitable, determined by socioeconomic and demographic status. And in the US, for all our expenditures, our massive expenditures and Obamacare, we still have about 30 million people without insurance. So that's a long way of saying this is an industry, inefficient, unknown quality, bars tens of millions of people from access in one way or another. That's just ripe for innovation. Innovation in medtech is hard, but not so hard. Innovation in delivery is very, very difficult. And the reason is that the status quo hospital systems and their affiliates are so powerful that it is very difficult to get past them and to innovate. Innovation, health insurance is actually a very innovatable industry because, surprisingly, it doesn't take that much capital to get into it. Most of the money in health insurance is prepaid by subscribers or by providers who provide services but are very lax in sending the bill. So financially, even though there are capital requirements for health insurance, it's not an industry unlike building a hospital where capital is a major barrier to innovation. But it's not a very innovative industry. And I think in insurance, the barrier to innovation is really the lack of knowledge about what a ripe area could be. We do have innovations like Oscar in New York, which uses telemedicine, has used it. It's really a technology-driven company. It's not public, but it's valued at between $3 and $4 billion. Bright in Minneapolis, which offers series of selected ACOs. Bind, also in Minneapolis, which offers on-demand insurance, which means it's really insurance. It insures you for catastrophically expensive things. And we have various capitated primary care insurers like ChenMed that offer care to different kinds of populations. But insurance is really a $2 to $3 trillion industry, and it's not a great industry. Most people really don't like their insurers. So you would think it would be brimming over with innovators, but to date, it is not. In the case of insurance, it's not that the status quo bars it. I think it's just lack of knowledge of what a great area it is, especially for people like your students, David, people who are interested in finance and interested in healthcare. The overall problem with innovation, other than barriers to it by the status quo or lack of imagination or knowledge about what can be done with a sector like insurance, is a sort of naivete about what it takes to innovate. So I meet many people and they have ideas, and their idea is, if I build it, you will come. But if you build it, they won't come. And it's not even clear that you should build it. So that's what my book and my courses are about. How do you judge if an innovation is viable? By viable, I mean, will it really do good in society or be just a free rider on some imperfection we have? And secondly, is it financially viable? And if it's viable, what does it take to make it a company, whether for profit or nonprofit? What does it take to make it happen?
You spoke of insurance innovation and plans offering catastrophic health insurance. Are high deductible health plans good for individuals? Are they good for society?
Well, clearly, if you median family income in the United States is 55,000, and employers who insure about 160 million people and who increasingly offer high deductible plans have been surreptitiously increasing the deductible. And it is certainly unaffordable for low to low medium income people. On the other hand, it is good for the user of services to know what the price is, whether the deductible is the right mechanism for making the consumer aware that an MRI here costs X and MRI there costs Y. I don't know that the deductible is the greatest way of creating that awareness. I do know that it should be, if they're going to use high deductibles, which employers are increasingly using, and increasingly surreptitiously high deductibles should be linked to income, because 5,000 to people like us who are fortunate is very different from 5,000 to a family that earns 50,000 a year. But insurance, among the many innovations that it lacks, is some sort of linkage to income, and it's grossly unfair to them.
I think that makes a lot of sense, linking the deductible to a person's income. Would that be a policy? Are you advocating that as a policy change or as a change by an employer?
Well, I would love for the employers to be much more transparent about what they're doing. And if they were more transparent, I think their employees would drive the kind of insurance policies they want. Over the past decade, the amount that employees have contributed to their health insurance premiums has gone up significantly, but the employees totally unaware of it. Meanwhile, the actuarial value, meaning what is the value, how much coverage do I get with my insurance, has gone down because the deductible has crept up. So without their knowing it, employees have been paying more and more of a very expensive purchase, $20,000 for a family that's valued at less and less. What I would like is for the employee to be fully informed about this, to say, last year you used to pay 26% of the premium. This year you're paying 28% of the premium, and this is the impact on your income. Furthermore, the policy used to cover 75% of your purchases, of your likely purchases, now covers 70%. And if you get sick, here's the impact on your income. Under Obamacare, there was something called Box 12. Ever hear of Box 12? No, of course not. So, me neither. So back until I started researching this, Box 12 comes at the end of the year and tells you the value of your health insurance. So it comes at a time when you're not picking health insurance, totally irrelevant. You think, what the hell am I getting this thing for? How about expanding BACS 12, this reporting requirement by employers, so they tell you how much you actually have contributed, more or less, relative to what you used to pay in the past, for what? And how does that compare to, let's say, the policies on the ACA menu or the policies that are offered by similar sized companies in the area? So, David, I think if employees knew that, they would say, cut it out. I don't want this high deductible. I want whatever. I don't think personally the deductible is all that effective in creating a consumer mindset. But let them pick what they want. And most companies offer a choice of one insurance policy by one insurer. If you created this transparency, I'm sure there'd be pressure not only to increase the variety of plans, but also the insurers. So there would be competition among insurers and competition among plans.
Let's stay on the topic of competition. You spoke earlier about incumbent hospitals. Would some competition for them be good? For example, from physician-owned specialty hospitals? Are physician-owned specialty hospitals good for society?
What I think would be great for society is the bulk of healthcare expenditures are for people who have chronic diseases or chronic problems. They can't walk, or it's not a specific disease, but it's a problem. Let's take a disease like diabetes. Diabetes costs about $200 billion a year, probably more than that, because many diabetics are unaware that they're diabetics. If you're a diabetic, you likely have 30 other problems. There is your diabetes, your heart is weakened, your kidneys are weakened. If you get a little sore in your foot, it won't heal because your circulation is so bad, becomes gangrenous, you may need it to be amputated. If your kidneys are impaired, diabetes destroys the circulatory system, you need dialysis, you're very depressed. Okay, so now you're a diabetic, you have this horrible disease. You need a whole army of other providers to work with you, and they have to be specialists. So the heart of the diabetic is different from your heart or my heart, requires not merely a cardiologist, but one who specializes in diabetic cardiology. Where did they find them? Don't know. And they're very sick, and their caregivers are very, very, very occupied just with the diabetes itself. So I think what we need is not specialty hospitals or specialty, which are hospitals that specialize in certain surgical procedures. We need a healthcare system that's organized by the healthcare needs of the populace, which is complete care for whatever chronic disease I have. And a specialty hospital could be part of that system. So a hospital that focuses on cardiac procedures on diabetic hearts, which are much more susceptible to all kinds of damage because of the destruction wrought by the diabetes itself, that would be okay. Probably would be part of a good system. In and of itself, Those hospitals are probably more efficient because they do just that, do a large volume of something. And if they're run by competent people, they ought to get better and better at it. But they may do too much of it. We have better oversight than we used to have of the overuse of facilities owned by physicians, but it's a problem. So there are pros and cons to the specialty hospitals, but are they going to save our healthcare system or those around the world that are drowning in red ink? No. What will save it would be to reorganize it around what people need, which is complete integrated care for their chronic diseases or disabilities.
The next segment is overrated or underrated.
Okay.
I copied this from Tyler Cowen. You know Tyler Cowen from the editorial page of the New York Times in the past. He has this great segment on his podcast, and I'll give you a phrase, and you'll tell me overrated or underrated, and feel free to pass.
Well, you know, David, as academics, we love to do this, right? To grade things. Okay, let's go. Let's go to
The case teaching method, overrated or underrated?
It is underrated. It is by far the most effective teaching method for teaching things like business, where you need to know how to do things, how to work with people, how to communicate effectively, how not to turn people off when you speak. How to order your project, how to get things done on time, how to create a team, how to inspire people. Those are not things you learn through a lecture, somebody just waving their finger and mouthing on and giving you 7 different ways of being an effective leader. You have to learn that by doing it, and that's what the case method is about. It requires the students to speak and at its best to actually do things. In my own course, I don't hold myself up as an exemplar of excellence, but just as an example. My students don't have the final exam. They have to do a business plan, and they have to work as a team. I've cross-registrants from the medical school, School of Engineering, Kennedy School, School of Public Health. They work together. I've had $7 billion companies come out of that course, and many smaller than $1 billion, not small, but very effective and important firms, including a newsletter, the newsletter for diabetics, that came from one of my students who is a diabetic. I think it'd be hard to do that in courses that focus on lecture. I tell you, you don't tell me. Your thoughts are, you're just a recipient of my endless well of wisdom, rather than being an active participant with me on creating something. Problem with the case method is it's very hard to teach. The cases are complicated. You have to actually listen to what your students are saying and remember what they're saying, so that 30 minutes into the class, you could say, hey, Alice, you said blah, and that's now being contradicted by David over here. So the instructor has to set up tension and theater and excitement in the classroom. It's a hard teaching method as opposed to a lecture. There are great lecturers, but you can use the same lecture again and again. You can't do that with a case method. So it's underrated. People say, what? But It's one for what we teach. Maybe not for anatomy or genomics, but for what we teach, it's wonderful, but it's very hard to do.
I agree, it is hard, but one thing that makes it much easier is having excellent cases to work with. And you are the author of some really fabulous cases.
Oh, thank you. I'm writing some new ones. I'm writing one on surgical imaging, focusing on a company called Brain Lab, because clearly surgery will be greatly transformed through surgical imaging technology. And I'm doing one on Humana. And Humana is an interesting firm that keeps reinventing itself. Started as a hospital firm, it's now going into home health and capitated primary care practices. And I'm doing one on Philips, which has the great Dutch company, which has a hospital to home program.
Reggie, it's been a pleasure and an honor to talk to you. I'm so grateful for the great work you've done, the fabulous cases you've written, and your latest books. Anything else we should know about how to find more information about your work?
Well, I was never on LinkedIn, but to get some feedback on my book, I joined it about 3 months ago. I've had incredible, really astonishing, and of course, very cheering to me, the level of interest. And in those posts, I've talked not only about issues in innovation healthcare. For example, why did Haven, the firm started by J.P. Morgan, by Jamie Dimon, brilliant banker Warren Buffett and Jeff Bezos from Amazon. So far, it would be hard not to call it a failure. Why did it fail? Started by the most brilliant business minds. I mean, only Elon Musk is missing from that starting lineup. So I have posts like that, but I also have posts on public policy. One that has created substantial interest is a post that argues for the creation of an SEC for healthcare that would force transparency and that would have the punitive powers of the SEC, the criminal and civil prosecutorial powers for not following its requirements. I am not a person whose mind jumps to government as a solution, but given the lack of transparency that I've observed, the voicing of the need for transparency and the toothless transparency tigers that have been created, I think we have to go to government's real public good to force healthcare transparency.
I'll look for your posts. I'm not following you on LinkedIn yet, but I am following you on Twitter, and I'll follow you on LinkedIn so I can see the post about Haven, and also so I can see the post about an SEC for healthcare.
Thank you so much, David. David, you're terrific. It's a pleasure to work with you.
It's always such a pleasure to talk to you.
Yeah, I'm sorry it's every 10 years, David.
My guest today has been Professor Regina Herzlinger. Thank you again, Reggie.
Thank you, David. Bye.
Bye.